This program is brought to you by Emory University.
It is my pleasure to introduce this morning's speaker, Dr. Christina Thaler. She is an assistant professor of medicine at Emory and joined our Adult Congenital Heart Center about a year and a half ago. She trained via the Adult Congenital Internal Medicine pathway and received her MD PhD from the University of Minnesota with a PhD in chemical engineering. She did her residency and cardiology fellowship in Minnesota and then went to the University of Michigan for adult congenital heart disease fellowship training. She also has additional training in advanced cardiac imaging. She is going to talk to us today about the adult presentation of congenital heart disease. Christina, I will let you take it from here. Thank you for being here.
Thank you so much. So I have no disclosures, and today we'll do some basic epidemiology of adults with congenital heart disease, review some common presentations and initial management for patients with adult presentation, although it cannot be comprehensive, and then discuss, using these case examples, some non-cardiac complications also. So first of all, what is adult congenital heart disease? It's structural heart disease present prior to birth that's attributed to abnormal fetal heart development. It does not include heritable diseases such as some of the aortopathies, although the Marfan syndrome and other related syndromes are part of the adult congenital boards, so any adult congenital cardiologist should be able to manage these syndromes. Hypertrophic cardiomyopathy and arrhythmogenic ventricular dysplasia are not included. So if we look at the classification, which I think is helpful to understand and also understand the recommendations for our most up-to-date guidelines, we break down congenital heart disease to simple, moderate, and great complexity. Simple is very simple, like a small ASD that doesn't need intervention, a small PDA, relatively small, simple, that don't have large hemodynamic consequences, all the way to our great complexity, which would be conditions like heterotraxy syndromes, or single ventricle patients, transposition of the great artery, pulmonary atresia would be great complexity with everything else moderate. We also break down by physiology, and the difference compared to our standard New York Heart Association classification, where it's supposed to be progressive, is that people can move up and down on this, depending on their surgical repair and their symptoms. And so stage A is no symptoms or physiologic consequences. Stage B is mild of any physiologic consequence. Stage C is moderate or greater of anything, and then D is end stage. If we look at the scope of congenital heart disease, it really is becoming an epidemic across the globe. Congenital heart disease is the most common birth defect, with 1% of newborns born with congenital heart disease. It used to be in the 1950s, about 10% of children born with congenital heart disease would make it to adulthood. And now in this modern era, it's expected greater than 90%, even with complex congenital heart disease, will make it to adulthood. In the United States, there's over 1.4 million people with congenital heart disease. About 2/3 are now adults, and we have about 20,000 patients entering adulthood per year. This is also similar to the European Union, and this is an old slide, but still very relevant, looking at the overall population of congenital heart disease with children is not changing, but the growth in adults is rapidly expanding. And then most notably also is the patients over 60 and more geriatric population is also expanding. This is some data, thanks to Dr. Book, that's unpublished, looking at in Georgia, trying to understand the overall scope of congenital heart disease. And this is pulling from the Birth Defects Registry, Clinical Cardiac Database, and SDS. So for the most part, these are people that have known, first of all, congenital heart disease and have had some sort of intervention. And for the state of Georgia, we're looking at 49,000 patients, with a very large portion of patients that are about to age into adulthood here. Looking at accredited centers across the country, these are all the centers that have an accredited program. And what's notable here in Georgia is that we are the only center with not a lot of centers close and nearby. So we have a fairly large catchment area for our population. There's not great data on patients presenting in adulthood. The best paper that looked at this issue is actually out of Korea, where a Korean medical center offered an elective echocardiogram for all patients coming in prior to a physical exam. And the interesting thing is they found about 1% of all of their echocardiograms that were done, which were purely screening for patients that did not necessarily have symptoms. They had a 1% hit rate for congenital heart disease. The most common was a bicuspid aortic valve that they found, followed by atrial septal defects. And the most common advanced or complex congenital heart disease was congenitally corrected transposition of the great arteries. What's notable in this list that they did not find is anomalous coronary arteries due to their screening method. A more recent paper was published out of Spain looking at consecutive patients in their group, and they found that 26% of their consecutive patients to adult congenital heart disease, which they defined over 16, actually were being referred in. So a little over a quarter. I think that's probably an overestimate compared to what we see here at Georgia. But the thing that was notable is only 28% of their patients actually had any symptoms at the time of diagnosis, but about half of those patients, when they did present at a later age, did have some sort of complication or needed interventions. So moving along in terms of some examples of patients that present in adulthood, our first case will be a 45-year-old with longstanding hypertension that was initially diagnosed with pregnancy, who presented to their primary care doctor with new onset of dyspnea on exertion and some atypical chest pain. And a very astute radiologist reading their chest x-ray that was obtained noticed some rib notching and recommended a further CT for further evaluation due to concern for aortic coarctation. And indeed, they had very severe aortic coarctation with an extensive collateral network. And right here, you can see the aortic coarctation. They underwent an echocardiogram, and I think what's notable is that in a lot of adults, it can be very hard to see the from the suprasternal notch, the aortic coarctation. And if you have an extensive collateral network, the diastolic runoff on spectral Doppler may not be as prominent as other times. And so you have to have a good clinical suspicion and be also realize that you may not always see aortic coarctation on your echocardiogram. On further history, the patient had symptomatic claudication with walking. They had a significant drop in their blood pressure from the lower extremities to the upper extremities, and ultimately underwent a surgical repair with an 18-millimeter interposition graft to the proximal descending aorta, and were subsequently lost to follow-up after. If we look at aortic coarctation, hypertension is very common in this patient population, and it increases with age. I often discuss with patients that I see this more as a vascular disorder than truly a complete structural disorder, with hypertension being one of the largest complications, and then the challenges that come with uncontrolled hypertension as the consequences of the long-term side effects of this condition. All patients should have resting blood pressures in their upper and lower extremities. Ambulatory monitoring can be considered, and exercise stress testing can also be considered in this patient population. Hypertension is often undertreated, and a UK cohort study that looked at all patients with no incoarctation in the United Kingdom found only 18% of their patients were actually appropriately treated, and my suspicion is the United States is not that far off from the United Kingdom. The UK cohort study also looked at the overall population and survival compared to age-matched control patients, and what was notable is they started to see a drop-off in the 30s and 40s of overall survival from the patients with aortic coarctation. They had a median age of death of 46 with a large range between 37 and 62 years. One of the risk factors was having a prior VSD or LVOT obstruction with a higher risk of death. And their most common cause of known death was LV systolic heart failure. And the interesting thing that surprised them is that in the post-op period for non-coarctation repairs, that seemed to be a much higher risk for death compared to what they would have expected for surgeries in that patient population. I think the other thing that is notable is there are some studies looking at overall survival for patients with aortic coarctation, which are often done, having surgery as children, and they look out 20 years and showed excellent survival, which goes along also with what has been shown here, The challenge is that this only looks out to here, which is exactly what the cohort study is. And we really need to look at, even for conditions that seem slightly simpler, later in life, what happens in terms of 40 plus. And that's what we don't have a lot of data for many of our different conditions. Lower survival is also noted when coarctation is repaired in adulthood. And so finding these patients at a younger age can affect their overall longevity. If we look at indications for intervention, an upper to lower extremity resting peak to be gradient of greater than 20 millimeters of mercury, or a 10 millimeters of mercury if you have decreased LV systolic function, aortic regurgitation, or collateral flow. The European guidelines include a 50% narrowing with hypertension, but the US guidelines do not. The other thing that's notable is the method of repair has changed over time from primarily a subclavian flap repair to now an end-to-end anastomosis repair. It's important to recognize if patients have had a subclavian flap repair, which often, even without imaging, you can take just from the pulses in their arms. The challenge with a subclavian flap repair is that arm that has the subclavian flap is collaterally filled, and it's important to recognize, especially for patients that they come in medical emergencies and may not be able to speak for themselves, because I've had more than one patient either show up into the emergency department or get admitted to the ICU where the blood pressure monitoring is being done from the collaterally filled arm, and they have dangerously high blood pressure that's all iatrogenic. And so I encourage patients to always, for subclavian flap repairs, put it in their cell phone and then also educate their family members. Reintervention for aortic coarctation is common. The surgical patch repair has the highest risk for reintervention. The complications are at the site of the aortic coarctation include aneurysm, pseudoaneurysm, recoarctation, and dissection. Because a lot of the aneurysms and pseudoaneurysms cannot be seen by echocardiogram, patients do need cross-sectional imaging to follow for these complications. A bicuspid aortic valve, at least 50%, and in some series much higher rates, are associated with aortic coarctation. Patients with just a bicuspid valve also need to be screened for aortic coarctation for extremity blood pressures. And so I encourage anyone that's seeing patients with bicuspid to at least document once the 4 extremity blood pressures and make sure that you're not missing an aortic coarctation. Intracranial aneurysms are a controversial topic. They have been shown to occur in about 10% of patients, but this was a Mayo study that looked at patients that were older, so in their late 30s and 40s, and had about a 10% hit rate. This then was repeated in a pediatric population and young adults, and not a single patient was found to have any intracranial aneurysms. They're often small. They're more commonly seen in patients with hypertension. Most recently, the Mayo republished their same data, which again had about a 10% of patients with intracranial aneurysms. The main thing is that they then did repeat imaging, and what they found is when they took those patients that had or did not have aneurysms and looked at about 7 years later, and then another screening at about 6 years later after the second screening, they didn't find anyone with any new aneurysms. So perhaps really the time to be doing screening is in the late 30s, and if you don't see it, patients may not actually need further screening. These patients require lifelong cardiology follow-up for monitoring of the complications of aortic coarctation, and the rate of follow-up and imaging is dependent on their physiological stage. So in summary, hypertension is a very common complication. Bicuspid valves are associated with aortic coarctation at very high rates, and all patients with a bicuspid valve also need screening for aortic coarctation. Reintervention is common, and intracranial aneurysms can occur. Our next case is a 32-year-old who presented to primary care clinic for preoperative clearance for an orbital tumor. They were in order to have a murmur on exam and had worsening exercise tolerance, and so surgery was delayed for cardiac evaluation. An echocardiogram was obtained, and what they found and were diagnosed was pulmonary hypertension. They went on to have a heart cath and was discovered that they did not have pulmonary hypertension, but RV systolic hypertension with branch pulmonary artery stenosis. They ended up getting intervention on the branch pulmonary artery stenosis, and the decisions to intervene are based on RV hypertension, progressive RV enlargement, or decreasing RV function, and the distribution of pulmonary flow. Restenosis in this patient population is common, and they continue to need follow-up even after intervention. The thing that's interesting is this patient presented due to an initial cancer diagnosis, and there is an association in terms of increased risk of cancer. It's overall small, but it is real with congenital heart disease. A Swedish cohort study found an increased risk hazard ratio of 2.24 for development of any type of malignancy, and similar results have been found in cohort studies in many different scenarios, one from Taiwan, Canada, and then also California. Based on this information, I really encourage patients to have good primary care follow-up with all this normal screening, but there's no different screening that we do for our patients compared to the general population. So in summary, branch pulmonary stenosis can be a rare cause of RV hypertension. The interventions are based on symptoms and RV function or dilation. Restenosis can occur, and these patients continue to also need follow-up. Our next case is a 29-year-old pregnant woman with tachycardia who was referred to cardiology during her second trimester of pregnancy due to resting tachycardia and heart and dyspnea on exertion. She was noted to have a soft murmur at her right upper sternal border, and so an echocardiogram was obtained. She was noted to have an enlarged RV with left to right shunting across the atrial septum and a cleft mitral valve. It was noted that they could not fully figure out the extent of the atrial septal defect on echo imaging. During pregnancy, she had a cardiac MRI that noted a QP to QS of 2.3 to 1 with preserved biventricular function, an enlarged RV, and a very complex atrial septal defect was noted, which again was still not felt to be fully understood. She underwent post-pregnancy a CT scan, and what was noted is that she had a very complex atrial septal defect involving many different portions of her atrial septum, and this involved the coronary sinus, the ostium primum, inferior sinus venosus, and the secundum atrial septal defect. So if we think about types of atrial septal defects, it really depends on the area of the atrial septum that has the defect. What is notable is our secundum atrial septal defect that has a decent REMS. It's the only one by guidelines that we can close percutaneously, although there are new percutaneous interventions that are coming on and are being used more frequently for sinus venosus defects. The patient underwent a right heart cath, and that was noted to have normal right-sided filling pressures, normal left-sided filling pressures, and a QP to QS of 1.8 to 1, and ultimately underwent surgical repair after she was done breastfeeding. So if we look at atrial septal defect closures with left to right shunting, the important thing is looking at the hemodynamic assessment. So if pulmonary vascular resistance is less than 1/3 of systemic and the PA systolic pressure is less than 50% systemic with right heart enlargement and a large enough shunt, which is defined as greater than 1.5 to 1, it is recommended to close the atrial septal defect with the strength of the recommendation just based off of functional impairment. If you have an increased pulmonary vascular resistance or an elevated PA systolic pressure, then recommendation is to consult with ACHD physician or pulmonary hypertension, where consideration for pulmonary hypertension medications followed by device closure can be considered in that patient population. Patients with younger age have improved survival. And there's worse survival if you have elevated systolic PA pressures greater than 40 millimeters of mercury. If we look at the cardiac complications following surgery, younger patients tend to have a very low rate of complications, where patients over 24 years old have a higher risk, with heart failure and stroke being two of the most common complications. If we look at arrhythmias following atrial septal defect closure, The initial teaching was if you close less than 40 years of age, there's really not a significant increased risk of arrhythmias, versus above 40, there's an increased risk. And this is only looking at 5 years out of surgery. The challenge with this data is that you're comparing very young patients to a much older patient cohort, which what has not been looked at when this was published was what happens when the young patients become into their 40s and 50s. Do they actually have an increased risk of atrial arrhythmias? And indeed, it looks like that may be true. So a Danish registry study looked at patients that had closure between 18 to 24 years, and they found a 22% rate of development of atrial fibrillation with the median age at 49 years. A Mayo cohort study also found similar results, where they found 22% of late deaths were secondary to stroke, and all these patients had atrial fibrillation or atrial flutter. So if we look at anticoagulation with atrial fibrillation and congenital heart disease, the US guidelines do not take a stance on this topic, but the European guidelines do address this topic. The European recommendations are all patients should have oral anticoagulation if you've had an intracardiac repair, cyanosis, Fontan palliation, or a systemic right ventricle. In addition, they also recommend that when patients go into atrial fibrillation, they recommend a transesophageal echocardiogram along with anticoagulation prior to cardioversion. And so just putting someone on 3 weeks of anticoagulation, they do not see as sufficient. Some of this data and recommendations is based off of the European cohort studies looking at these increased risks of stroke and increased risk of death that appear to be driven for strokes by atrial fibrillation with strokes. And therefore, the standard CHA2DS2-VASc score for congenital heart disease patients may not be sufficient for truly estimating risk of stroke. All patients, though, still should have also the standard risk assessment. And if you have an elevated CHA2DS2-VASc score, that's even more important to consider for anticoagulation. Surgical treatment for atrial septal defects is superior to medical treatment in patients over 40 years old when you look at the primary endpoint of death, pulmonary embolism, major arrhythmic events, strokes, pulmonary infections, or functional class deterioration. Interestingly, in the sub-analysis for this paper that looked at surgical treatment being superior, it was driven really by the functional class and recurrent pulmonary infections. The most feared complication of an atrial septal defect is the development of Eisenmenger syndrome. And unfortunately, if patients don't have a large murmur, this can go undetected until they present with Eisenmenger syndrome. This is an echocardiogram of a 54-year-old woman that I've taken care of who presented with atrial fibrillation and New York Heart Association class 3 to 4 symptoms. She was counseled on her condition. She elected just to take rate-controlling medications and diuretics and declined pulmonary hypertension treatment and died 3 years after her initial presentation. Survival in these patients, though, is significantly improved with pulmonary hypertension treatment. Based on the guidelines, bosentan is a class 1 indication with PDE5 inhibitors as a 2A indication, and a consideration to use both medications can also be considered. This patient population, ASD closure is contraindicated, and the most notable thing is with pulmonary hypertension treatment, these patients can live significantly longer than standard patients with pulmonary arterial hypertension. And some of the newer pulmonary hypertension therapies that are coming onto the market now are also starting to be considered for this patient population, although none of those have made it into the guidelines at this point. So all patients with atrial septal defects should have a lifelong cardiology follow-up, monitoring for atrial arrhythmias, change in shunt size, pulmonary hypertension, and heart failure. And in conclusion, this is one of the most common conditions that can present in adulthood. Survival is reduced with late closure, with atrial fibrillation, heart failure, and stroke being the most common complications. Our next case is a 36-year-old woman with chest pain during exercise. She developed syncope at age 15 years and did not receive any evaluation. At 28, she was noted to have a murmur and was told this was likely mitral valve prolapse and did not need further follow-up. She did note that in her 20s, she felt active, but always felt to have a poor exercise endurance despite significant training for marathons. At age 36, while she was training for a triathlon, she had some chest tightness and presented to an emergency department for evaluation and was noted to have EKG consistent with a myocardial infarction, and they recommended an outpatient echocardiogram. She was diagnosed with congenitally corrected transposition of the great arteries. These patients often have a tricuspid valve, which is here, that is either dysplastic or Epstein-like. So congenitally corrected transposition, the anatomy is that you have a right atrium that connects to a left ventricle to your pulmonary arteries. Blood then returns to your left atrium, goes across the tricuspid valve to a systemic right ventricle that then goes to the aorta. This condition is caused by abnormal L-looping of the primitive heart tube, and it can be associated with no other defects, or often a ventricular septal defect can also occur with these patients. The coronary anatomy for these patients is mirror image of the normal anatomy, and a right coronary artery always goes with a right ventricle, and the left coronary artery goes with the left ventricle. The challenge with this patient population is a right ventricle was really not designed to be a systemic ventricle, and the right coronary artery really was not designed to provide blood flow for a systemic ventricle. Heart failure is very common in adulthood, and if patients live long enough, is almost universal, with the development of moderate to severe RV dysfunction really increases as patients age. Medical treatment for heart failure is very controversial, and this topic actually delayed significantly the publication of our most recent congenital heart disease guidelines. So the compromise to get the guidelines published was to do a systemic review to look at this topic. The challenge is the studies that go in to looking at medical treatment for systemic RVs are severely underpowered. The entire analysis had 187 patients, which concluded both the control and the treatment group. Patients were included with both D and L transposition of the great arteries. These studies had up to a 50% dropout rates. People were included with a normal or near normal systemic RV function, and the follow-up time was as short as 4 months. So based on this, I see it as more of a lack of data that we still have for this patient population, other than that some of these studies did show that it can be safe to consider goal-directed medical therapy. Not all patients tolerate it well, and so it can be tried, and if patients don't tolerate it, you can withdraw it, and I just counsel that there's not great data to begin with that it actually helps. Patients can start to have an elevated BNP prior to seeing a decrease in their systemic RV function, and so many centers are moving towards following the brain natriuretic peptide closely, and then starting GDMT once the BNP starts elevating, and if patients don't tolerate the medication, then it's just withdrawn. For follow-up, this patient then was started on an ACE inhibitor and did have some stabilization in their systemic RV function, with maybe even some improvement. They then developed atrial arrhythmias. They had non-sustained ventricular tachycardia, atrial flutter, then developed a Mobitz type 2 AV block, and that progressed then to complete heart block and received a dual chamber pacemaker. Rhythm abnormalities in congenitally corrected transposition of the great arteries is very common. Need for pacemaker is common. It's more common if you have associated abnormalities such as ventricular septal defect compared to an isolated transposition. Arrhythmias are also common for this patient population, and the most feared and challenging condition is sudden cardiac death. One series looked at 5 of 39 patients that they had ended up presenting with sudden cardiac death. All the patients with sudden cardiac death had a normal to mildly reduced RV systolic function with very little symptoms prior to this occurring. There's some thought that sudden cardiac death could be mediated by atrial arrhythmias that lead to elevated tachycardia and then ischemia because the right coronary artery can't support a systemic RV, and then that degenerates into ventricular tachycardia and sudden cardiac death. However, this is all speculation, and we don't have great data for that. On follow-up, the patient then developed moderate to severe tricuspid valve regurgitation and had a declining systemic RV function. Based on that, they received a bioprosthetic valve in the tricuspid position. They had early endocarditis, which is unusual for patients. That was managed medically. 6 months post tricuspid valve replacement, they had increasing gradients to 16 to 20 millimeters of mercury at a relatively low heart rate, and were started on warfarin with complete resolution of their gradient. Tricuspid valve regurgitation in congenitally corrected transposition is extremely common with or without associated lesions, with over 80% having any degree of tricuspid valve regurgitation. If we look at survival, it's worse if you let the systemic RV go below 40%. So the goal is to try to replace a systemic tricuspid valve for moderate or greater regurgitation while you still have an improved systemic RV function. Survival is also worse if the pulmonary pressures are over 50 millimeters of mercury. Tricuspid valve replacement is favored over repair. People have tried to do tricuspid valve repairs, and for the most part, they have not held up. Often, the tricuspid valve is either very dysplastic or Epstein-like, making the repair much more difficult. And so based on this, if you're going to go in and do a procedure, it's recommended to replace the valve. These patients are very complex. They need close long-term follow-up, even without any symptoms, monitoring for heart failure, arrhythmias, and systemic tricuspid valve regurgitation. So this is the most common condition that can present in adulthood. Heart failure is almost universal if patients live long enough. Arrhythmias are very common. And like I said, tricuspid valve regurgitation is common. The thing that's notable for this condition is that this often will present to the echo lab. And so it's important for echo readers to be able to recognize when they see this condition. So in conclusion, congenital heart disease can present in adulthood. It's often initially diagnosed by an echocardiogram, with the initial presentation often being atrial arrhythmias or heart failure in a young patient. If we look at congenital heart disease across all different types, there's an increased mortality when you compare it to the general population. And so what this figure showed is for a patient at age 40, what is the equivalent age across different conditions? And what's notable is there's only a very small increased risk for atrial septal defects compared to Fontane's have a much higher mortality rate at age 40 that's predicted, with the other conditions somewhere in between. But all different conditions all have an increased mortality compared to the general population. There is also an increased risk for recurrence of congenital heart disease in patients' children, for both men and for women. So echocardiogram with a fetal echocardiogram around 20 weeks of gestation can be offered to all patients who have congenital heart disease. The thing that's notable is not always the same lesion can occur. So one of the very first patients I saw as a fellow was a patient with an atrial septal defect that was fairly unremarkable other than needing to be surgically corrected. And that patient had a patient with a single ventricle requiring a Fontan. Other patients with Fontanes can have children and they could have no congenital heart disease or just really minor. So again, it does not go in terms of we don't understand the genetics and why do some people have what they have, and then also what the actual genetics of this condition are. Overall, treatment is improved with being for patients when they're treated at a comprehensive adult congenital program. So in Canada, they looked at what was the overall mortality rate for patients that were taken care of at a congenital center versus general cardiology, and they were actually able to show a benefit and improvement in survivability by having appropriate treatment for this patient population. So congenital heart disease is a lifelong condition that can present in adulthood. It's often diagnosed by echocardiogram, and these patients are complex. They need multidisciplinary care by many different specialties and also by other specialties outside of cardiology also in order to improve their outcomes and make them feel better and live longer. like I said, congenital heart disease is a very multidisciplinary specialty. And so I want to thank many of all the different people in our program and are associated. And if I missed anyone, I apologize. But this is a huge group, and we appreciate everyone that helps us take care of these patients. And we're always looking for more general cardiologists that we can also partner with, because based on the size of the population, there's no way that just congenital heart disease specialists are going to be the only providers for these patients. And so we really have to move towards partnership for all of our patients. And with that, I will open it up to questions.
Thank you, Christina, for excellent talk on congenital heart disease. While we are waiting for questions, what do you think is the biggest challenge that these patients face, and what is the biggest challenge that the field of adult congenital heart disease faces?
A hard question. I think from a patient perspective, often one of the biggest challenges is access to care. And even if they have access to appropriate care, is the financial aspect, because care for these patients is very expensive. From an imaging standpoint, follow-up procedures, and many of our patients are young and do not necessarily have adequate insurance. So being underinsured or no insurance, I think, is a huge challenge. And if we look at the patient population, only 50% of patients have private insurance, where the rest of the other 50% have either Medicaid or no insurance, or Medicare. And so that is one challenge of the patients. I think as a field, it's really the growing population is that we are not training enough people to take care of these patients. And I don't see that changing anytime in the near future. So really, I think we have to shift to a new way of how do we optimize care for a population across all the patients with congenital heart disease. And I think that's one of the biggest challenges that the field is going to face moving forward.
Yes, definitely workforce challenges. We went from a specialty that 20 years ago was thought not to be needed to one with a shortage of providers. We have a question in the chat from Brian Wells. What modality do you use to screen for coarctation in bicuspid valve? And who with bicuspid valve do you screen for intracranial aneurysms?
So I only screen aortic coarctations for intracranial aneurysms. The challenge that I have is a lot of times when we are screening, we're doing it in young patients, or they've come in with screening in their 20s. And I don't necessarily see that as sufficient, because I think that patient population is closer to the pediatric population, where we just don't see intracranial aneurysms. I still will offer it in their 20s, and then I will consider repeating it when they're closer to 40, or if we're considering doing a major surgery. So if they're going to go on bypass and we're giving a large amount of heparin, I will rescreen at that time point also, because we may want to know of whether or not there's a significant aneurysm. I've only had one patient where we actually had to intervene on an aneurysm prior. Otherwise, most of them are very small, but I do think it's helpful to know about. From aortic coarctation, I will screen with echocardiograms and then upper and lower extremity blood pressure. Patients with bicuspid valve, because there is an association with having an ascending aorta dilation, I'll sometimes get a baseline and then use echo after that from cross-sectional with MRI or CT, and then make sure that I request that people look at the region for aortic coarctation with that initial screening also.
So have we swept the EKG by the wayside? Is it worth anything in screening? For example, can a patient with ASD have a normal EKG? It's the same question of Oslam about hypertrophic cardiomyopathy. Can a patient with hypertrophic cardiomyopathy have a normal EKG? Oslam says yes. I guess the answer is yes in ASD, but things
Many
like
of these patients do have abnormal EKGs, which also can lead to screening. I think the challenge is it's been very hard to prove a benefit in many different cases of just screening by EKGs on a population basis to really show it's cost effective.
Right, right. So I know we don't use EKG like we used to define right ventricular hypertrophy or left ventricular hypertrophy or biventricular hypertrophy. But probably somewhere outside of Atlanta, folks notice an abnormal EKG, which then requires that we define the anatomy. Then we get into the exact anatomical diagnosis, whereas years ago, there used to be a struggle to try to define the anatomy. Nowadays, we have such wonderful anatomic definitions by echo, by MRI, by CT, that once we get those, we're on to the situation. Many times, these patients require pacemakers, and once you get the pacemaker, that kind of upsets the apple cart of being able to make a diagnosis. Of course, Epstein's anomaly is one of the classic ones in which you diagnose on EKG. And so there are a few of them out there that you, if I showed you the EKG on them, you would say, oh, there's Epstein's anomaly. Or there might be an ASD present. Or there might be right ventricular dysplasia. So it does have some value, but it's faded away in the background a little bit. And I've always felt there's probably more information there than I notice our fellows don't pay much attention to it when I ask them questions about it. Anyway, it has some value, but we have such other beautiful imaging modalities that it's kind of fallen by the wayside a little bit.
Yeah, but I do think it'd be helpful. And if you're seeing things that would suggest congenital heart disease, because our imaging is also not always appropriate, it definitely can make you ask, saying, hey, do I need to go looking further for other conditions, or was this missed? Because a mild Epstein anomaly can be missed. A lot of the different conditions that if you're not thinking about it, can be missed by even a screening echocardiogram.
And of course, we use it for look at AV conduction, which is often a common problem.
Yes.
That was a great presentation. Thank you. I like those images, those CT and MRI images.
Thank you.
Thank you, Steve and Christina, both to your point. I think we do need to be mindful of care availability in different areas. We certainly can screen aortas, for instance, by echo here, but that may not be the case in other areas of Georgia where three-dimensional imaging may be more appropriate. And similarly, there are certainly areas where imaging is not available at all, and that ECG can be extremely important in understanding what's going on with the patient. Pooja, you have a question in the chat. The limited national data on TGA that Christina highlighted is abysmal. You didn't put that in the chat, but I'm going to edit your chat to say it is lacking. And you're wondering about an ACHD database at Emory where those patients are captured. Christina, you want me to answer that?
That would be great.
Okay. Pooja, we do have a 10-year surveillance database in which these patients are captured. There is a lot of challenges with the data in there, but there is information available both here and in other states that has yet to be analyzed, but hopefully soon.
Great. So we have an ACHD database that captures all CHD, or is it specific sort of cyanotic or?
We, through the surveillance work we do with CDC, we capture all heart defects, and we have a 10-year surveillance period for those patients that will be extended another 5 years fairly soon.
That's great. Because I feel like whenever I'm on Hearst, I feel like I've seen at least one TGA every time. So I'm like, I'm sure we have about 100 just at Emory.
Yes, yeah, we do. And there's a great deal of variability in these patients in terms of ventricular function, valve associated anomalies, and their outcomes over time. We certainly see TGA patients who make it well into their 60s without really needing anything done. And on the pediatric side, they have some that fail very early in childhood and go on to transplant. So it's an interesting, a heterogeneous group of patients. All right. Well, with that, Christina, thank you so much for a overview of congenital heart disease in the adult. Hopefully, this information will be helpful in guiding people as they manage these patients.
The preceding program is copyrighted by Emory University.